Welcome back to the deep dive. Today we're jumping straight into a really critical topic in pharmacology. Chapter 47, Antifungal Drugs.
Yeah, this is essential stuff.
Our goal here is simple. Give you that knowledge shortcut. We'll pull out the key concepts, how these drugs work, the side effects, and, crucially, the nursing rules you absolutely need.
It's definitely a challenging area. We're dealing with microbes, fungi that are way more complex than bacteria.
Right. And the drugs used against them can be pretty harsh.
Exactly. So we'll take it step by step. First, defining what fungi are, that how the drugs hit them, and finally, how you actually use them safely in practice.
Okay, let's get into it. Fungi are eukaryotic. That's the big difference from bacteria, right?
Fundamentally, yes.
Yeah.
And the ones that cause infections fall into, well, two main types.
You've got yeasts first.
Single-celled. They reproduce by budding.
Okay.
Think baking and brewing. But also infections. Candida is the big one there.
And the other type.
Molds. These are multicellular. They have these long filament-like things called hyphae.
Right, and when those hyphae clump together, you can actually see it. That's the mycelium.
Correct. And any fungal infection, doesn't matter if it's just like annoying itchy skin or something really serious deep inside, we call it a mycosis.
And specifically for skin, hair, or nail infections.
Those are caused by dermatophytes, and the infections themselves are dermatomycoses. Think athlete's foot, ringworm, that kind of thing.
But the real focus for these powerful drugs isn't usually the surface stuff, is it? It's the pathological fungi causing systemic problems.
That's precisely. Those are the life-threatening ones. And they tend to hit people whose immune systems are down.
Like who specifically?
Well, think about organ transplant patients on immunosuppressants, cancer patients getting chemo, patients with AIDS. Their bodies just can't fight the fungus off. And interestingly, even broad-spectrum antibiotics can be a risk factor. They wipe out your normal protective bacteria.
Leaving space for fungi like Candida albicans to just take over.
Exactly, which is why things like oral thrush, oral candidiasis, or vaginal yeast infections, vaginal candidiasis, become so common in those situations. We're up against a pretty clever opponent.
Okay, so we know the enemy. Killing it is the hard part, right? Because fungal cells and human cells are, well, surprisingly similar.
That's the absolute crux of it. The trick is exploiting the few key differences.
And the big one is?
Ergosterol. Human cell membranes have cholesterol. Fungal cell membranes have ergosterol. That difference is the main target for many of our best drugs.
Got it. So let's break down the four main drug classes. First up, the polyenes. Amphotericin B and nystatin are in this group. How do they work?
They're kind of the brute force method. They directly bind to that ergosterol in the fungal membrane.
And what happens then?
Well, once they bind, they form channels, basically punching holes right through the membrane. This lets vital stuff like potassium and magnesium leak out of the cell.
Which kills the fungus.
Yeah, it messes up the cell's metabolism completely, leads to cell death. Effective definitely, but, well, not subtle.
Okay, that leads us to the next group. The azoles, like fluconazole, and the allanines, like carbinifine. You call these the hole punchers too, but they do it differently, right?
Totally different mechanism.
Yeah.
They're more targeted. Instead of smashing holes in the existing membrane, they stop the fungus from making a good membrane.
How?
They inhibit specific fungal enzymes, cytochrome P450 enzymes, different from ours, which are needed to produce ergosterol.
So they block the production line.
Exactly. So the fungus can't make ergosterol. Instead, it makes these faulty substitutes, methylsterols.
And that results in?
A leaky, defective membrane that just doesn't work properly. So polyenes wreck the existing wall. Azoles prevent a proper one from being built.
Okay. Then we have the echinocandins, caspofungin, for example. These don't mess with the sterols at all.
Nope, completely different target. They go after the fungal cell wall.
The wall, not the membrane.
Right. They block the synthesis of glucans. Glucans are vital parts of that fungal cell wall. And here's the key safety point. Human cells don't have glucans at all.
So these drugs are highly specific to the fungus.
Very much so. It gives them a good safety profile in that respect.
And the last class, the antimetabolites, like flucytosine.
Yeah, this one works from the inside out. It's pretty clever, actually.
Also.
Flucytosine gets taken up by the fungal cell. Inside, there's an enzyme called cytosine deaminase, which, again, human cells don't have.
Okay.
This enzyme converts flucytosine into something called 5-fluorouracil, or 5-FU.
And 5-FU is bad news for the fungus.
Very bad. It directly interferes with the fungus's DNA synthesis. And because our cells lack that crucial first enzyme, cytosine deaminase, we don't convert flucytosine to the toxic 5-FU. It's a targeted internal sabotage.
That's fascinating. Okay, so we understand how they work. Let's talk about what they treat. Despite all these newer, maybe safer options, the go-to drug for really severe systemic fungal infections is still amphotericin B.
That's often the clinical reality, yeah. For really serious stuff, systemic aspergillosis, candidiasis, histoplasmosis, ampho-B is incredibly effective. It really does save lives.
But it's tough to use. Injectable only, and the toxicity.
That's the major trade-off, absolutely.
What about its relative, nystatin?
Similar mechanism to ampho-B, but it's just too toxic for systemic use. So you see it mainly topically or as an oral suspension for things like thrush or fungal diaper rash. No IV nystatin.
Right. Now, the azoles, fluconazoles, much better safety profile than ampho-B, you said. What makes it clinically useful?
Well, first, its pharmacokinetics are excellent. You get great levels from an oral dose, often as good as IV.
It's handy.
It is, but the real standout feature, it crosses the blood-brain barrier really well, gets into the cerebrospinal fluid, the CSF.
Which makes it key for
Treating things like cryptococcal meningitis, it's invaluable there. Also used as prevention prophylaxis in bone marrow transplant patients who are at high risk.
And other azoles, like voriconazole, are they for specific tougher fungi?
Exactly. Voriconazole has activity against some really difficult ones like Aspergillus species causing invasive infections.
Okay. And switching gears back to the allylamines terbinafine, where does that fit in?
Primarily, the oral form is used for onychomycoses.
Fungal nail infections.
Yep, fingernails or toenails. That's its main niche.
We keep coming back to amphotericin B being essential but so toxic. Why hasn't it been completely replaced if the azoles or echinocandins are safer?
That's a really important clinical point. Sometimes the newer drugs, while safer, just don't have the same breadth of coverage, or crucially, they don't penetrate into certain tissues as well as ampho-B does.
So for some really deep-seated infections.
For some deep, life-threatening infections, the proven powerful efficacy of amphotericin B outweighs the significant toxicity concerns. It's a tough calculation.
That calculation means serious risk management. Let's talk safety. General contraindications first.
Okay, standard stuff first. Definitely drug allergy. Then you need to be extremely cautious or avoid use in patients with significant liver failure or kidney failure. Also, porphyria is listed.
Any specific drug warnings?
Yes. Itraconazole, for example, shouldn't be used just for nail fungus if the patient has serious heart problems, like heart failure, because it can weaken the heart's pumping action.
That's critical.
And voriconazole is a definite no in pregnancy. The source material flags it as contraindicated due to potential harm to the fetus.
Okay. Now the big one, amphotericin B and the infamous shake and bake syndrome. This isn't just possible, it's often expected, right?
Pretty much, yeah. When you give it IV, you brace for infusion-related reactions. Fever, severe chills, sometimes low blood pressure, fast heart rate. Just general malaise can be quite dramatic.
So how do clinicians manage that? The source mentioned table 47.2.
Right. It requires a whole protocol. Pre-medication is almost always standard practice.
What kind of pre-meds?
Usually anti-nausea drugs, antiemetics, antihistamines, fever reducers like acetaminophen, antipyretics, and often corticosteroids, given before the ampho-B starts to try and dampen that reaction.
When the infusion itself?
It has to be slow. Very slow. Often over 2 to 6 hours. And constant monitoring, especially early on.
But the biggest long-term worry with ampho-B is kidney damage, nephrotoxicity.
Absolutely. It's a major risk. One common strategy to try and protect the kidneys is giving intravenous fluids like normal saline, maybe 500 to 1,000 milliraril, before starting the ampho-B infusion.
Kind of priming the kidneys.
Sort of, yeah. Trying to maintain good hydration and renal blood flow. And that's also why newer lipid-based formulations of ampho-B were developed, things like liposomal amphotericin B.
To try and deliver the drug more directly to the fungus and less to the kidneys.
That's the idea. Reduce the toxicity while keeping the efficacy. They help, but the risk isn't eliminated.
Okay, shifting from ampho-B's direct toxicity to drug interactions, especially with the azoles. The cytochrome P450 system is key here, isn't it?
Hugely important. This enzyme system in the liver breaks down countless drugs, including many azole antifungals.
So what's the danger?
The danger is competition. If a patient is taking, say, fluconazole, and they're also taking another drug that gets broken down by the same P450 pathway.
They compete for the enzyme.
Exactly. Which means one or both drugs might not get metabolized properly. Their levels in the blood can rise, sometimes dramatically.
Can you give us a concrete example, like a really risky one?
Sure. Think about warfarin, the blood thinner. It's metabolized by specific P450 enzymes. Now, fluconazole inhibits some of those same enzymes.
Oh, no.
Yeah. If you add fluconazole to someone stable on warfarin, the warfarin breakdown slows right down. Its levels shoot up.
Waiting to.
Potentially dangerous over-anticoagulation. Risk of serious spontaneous bleeding. That's why you have to get in meticulous drug history prescriptions, over-the-counters, herbals, everything before starting these antifungals.
That really underscores the importance of the nursing role, which brings us right to the nursing process. Before you even think about giving the first dose of any antifungal, what are the absolute must-do assessments?
Baseline checks are non-negotiable. You need baseline vital signs, definitely weight, a CBC with differential and, crucially, liver function tests, LFTs, and kidney function tests, KFTs.
Because of the known liver and kidney risks.
Exactly. You need to know where the patient stands before you potentially stress those organs.
For amphotericin B specifically, what does the nurse need to check right before hanging the bag?
Confirm those pre-medication orders are written and have been given, and keep a close eye on that IV site. Ampho B can be really irritating to veins, causing phlebitis.
Okay. What about for caspofungin? Any specific monitoring points?
Yeah, with caspofungin, you're watching blood pressure and pulse closely. Hypotension and tachycardia can happen. Also keep an eye on liver function tests and blood counts, red and white cells.
All right, let's talk implementation. Giving these drugs IV isn't casual.
Definitely not. Amphotericin B absolutely needs an infusion pump for accurate rate control. You can't just let it drip freely.
And monitoring during the infusion.
Vital signs need checking frequently, especially at the start, maybe every 15 minutes initially. If the patient has a severe reaction like sudden breathing difficulty, a big drop in blood pressure, severe chills, you stop the infusion immediately and notify the prescriber.
You mentioned baseline weight. There's a key rule about weight gain during therapy, isn't there? Related to the kidneys.
Yes, this is critical. A weight gain of 1 kilogram, that's about 2.2 pounds or more in just 24 hours, or maybe 2.3 kilos, about 5 pounds. Over a week.
That's a red flag.
Huge red flag. It could mean the kidneys aren't handling fluid properly, possibly due to drug toxicity. It needs reporting right away.
Okay, let's switch to an oral drug. Nystatin suspension for thrush. How do you make sure it works best?
This is all about patient teaching. You instruct the patient to swish the liquid thoroughly all around their mouth. Really get it in contact with all the white patches, the lesions.
For how long?
As long as they reasonably can before swallowing it. Maximize that local contact time. That's how it kills the fungus directly in the mouth.
Good tip. And voriconazole. Any special instructions there?
Yes, timing matters for the oral dose. It needs to be taken either 1 hour before a meal or 1 hour after, not with food.
And a specific side effect to watch for.
Visual changes. Nurses need to assess vision and specifically warn patients about the possibility of photophobia, increased sensitivity to light. They might need sunglasses even indoors.
Okay. What about general patient teaching points for anyone on antifungals?
Good hygiene is always important, especially hand washing. For women being treated for vaginal yeast infections, advise them to avoid sexual intercourse during treatment.
And do they need to stop treatment if they get their period?
No, absolutely not. They need to continue the medication for the full course, even during menstruation, to fully clear the infection.
And for someone on caspofungin, what signs would warrant an immediate call to their healthcare provider?
Any signs of a possible allergic or hypersensitivity reaction, shortness of breath, wheezing, facial swelling, hives, a bad rash, those need immediate attention. So if we boil down this entire deep dive on antifungals, what are the absolute must-remember points? I'd say 3 things.
Go for it.
First, these drugs work because they target things unique to fungi, primarily ergosterol in the membrane or glucans in the cell wall structures our own cells just don't have. That's the key to their selective toxicity.
Okay, number 1, target unique fungal structures.
Second, amphotericin B. It's a powerhouse, life-saving drug for severe infections, but it comes with significant toxicity, especially the infusion reactions and kidney damage. Requires careful pre-medication, slow infusion, and close monitoring.
Number 2, Ampho B, potent but toxic, needs careful management.
And third, drug interactions are a huge risk, especially with the azoles because of that cytochrome P450 system. Always, always check for interacting medications.
Number 3, watch out for P450 interactions, Scotty.
Yeah.
That's a fantastic distillation of a really complex chapter.
Hope it helps.
It definitely does. You know, the source material really highlights this tension. Amphotericin B, this old toxic drug, is still often the best weapon we have for the worst infections. So here's something for you, the learner, to think about. When that level of toxicity is the price you pay for effectiveness, especially when newer, safer drugs maybe don't get into tissues quite as well. How does medical science balance killing the bug versus keeping the patient safe? It's a constant ethical and clinical tightrope walk in drug development, isn't it?
It absolutely is. Understanding that balance is fundamental to good clinical practice.
Thank you so much for walking us through that, and thank you for joining us for this deep dive. We'll catch you next time.